overt physical or mental abnormalities. Upon further observation of the patient, he reveals having dizzy spells and a fear of heights. The patient has witnessed 3 traumatic events involving heights. Through the observational period, the patient became preoccupied with Madeline and reports seeing the image of her in strangers everywhere he goes. The patient also has flashbacks and nightmares. There is, however, no evidence of suicide or homicidal threats. Now I'd like to move on to the diagnosis. In Axis 1, he has post-traumatic stress disorder, a specific phobia, which is the natural environment type, acrophobia, or fear of heights. He also has a conversion disorder, which is vertigo, and it seems to be connected to his acrophobia. On Axis 2, there is no diagnosis as of yet. On Axis 3, we have vertigo caused by acrophobia. On Axis 4, he was forced to retire from the police force due to his acrophobia from the incident, and he does have few friends. In fact, we were only able to find one close friend of his that he could confide in and talk to. On Axis 5, on the global assessment of functioning, as his highest score, I gave him a 70 because other than his fear of heights, on most days he is able to function normally and carry on with his daily routine. On the lowest GAF, I gave him a 35 because he did have to retire from his force, so it did affect his job greatly, and he also had a blackout period, had debilitating nightmares and flashbacks, and was briefly put into a mental institution at one point. Alright, now I'd like to move on to the prognosis. I do believe the prognosis for the patient for his post-traumatic stress disorder, his acrophobia, his vertigo, and his obsessive thoughts is optimistic due to the fact that the age of the onset, being middle-aged, his friend support, and his willingness for treatment. Now I would like to discuss a little bit about the biopsychosocial formulation. The patient is suffering from post-traumatic stress disorder, which was initially brought about by the threat of his own life when he almost slipped off a roof and witnessed the death of a coworker. The disorder was aggravated by witnessing 2 other traumatic events, watching 2 women fall from the top of a bell tower. The patient also seems to have obsessive-compulsive disorder, or OCD, which often co-occurs with post-traumatic stress disorder. His obsessive-compulsive disorder presents itself in the form of his obsession with Madeline after he has already experienced a traumatic event. The patient is also suffering from acrophobia, which is a situational type of phobia brought on by a non-conditioning traumatic event. This was also caused by hanging from the roof while watching a coworker fall to his death below. The patient suffers from vertigo, which seems to be connected to his acrophobia since the symptoms only occur when he is in high places. I would now like to present you a treatment plan I believe would be beneficial for the patient. For the patient's post-traumatic stress disorder, the trauma should be explored through art therapy combined with psychotherapy. The patient would be asked to draw the traumatic events as he sees them in his mind. Then the patient and the therapist would discuss how he feels looking at the drawings and draw the feelings associated with the traumatic events, such as guilt, anger, depression, anxiety, etc. The therapy should begin once a week, and the patient will be asked to keep a journal to record any flashbacks, dreams, or thoughts he may have about the traumatic event or about Madeline herself. The journal should be brought to each session so that the entries can be discussed and responded to, perhaps in a drawing or a painting. It may benefit the patient to temporarily be put on the MAOI phenelzine during the beginning stages of therapy if the nightmares and flashbacks are interfering with his daily routine. Desensitization treatment along with art therapy should be used to treat the patient's acrophobia and related vertigo. For example, treatment could take place on a fire escape. The therapist would want to accompany the patient on the fire escape for the first few sessions. The patient will be asked to step onto each step and look down for 30 seconds, describing how he feels until he reaches the point where he is unable to do the exercise anymore. The patient will be asked to draw the anticipated emotions and physical reactions before each session and draw the actual emotional and physical responses after each session and rate their level of anxiety on a 1 to 10 scale at the beginning and the conclusion of each session. It may also be helpful for the patient to make a list of words associated with the experience during each session. This therapy should continue until the patient reaches the top without severe emotional or physical reaction. Are there any questions from anyone? Thank you and have a wonderful day.